Welcome back to the Only Healthcare Podcast. Our episode today features a guest speaker who will contribute to the conversations around commercial market needs and the benefits of employer-manufacturer collaboration. Specifically, we want to explore and begin looking at opportunities for solutions around data, equitable access, and whole person care. A reminder to everyone that you can always connect with us at www.onlyhealthcarepodcast.com and subscribe to stay informed and be part of the conversation on how we can drive positive change in the healthcare system. Now I'd like to introduce my co-host, Michael Navin, who will introduce our guest contributor and lead our conversation today. Michael?
Thanks, Randy, and thanks everyone for joining and signing in again. We're excited today because this is the first podcast we've put out there that includes a guest, and we have a great guest today. So we're really blessed to be joined by Zak Kornblum, who comes to us from Marsh McLennan. I got the privilege of meeting Zak about a year and a half ago at a pharmaceutical conference where really what was great is Zak comes from the employer and pharmacy side, and he kind of opened his eyes a little bit to what the manufacturers are dealing with. And so what we wanted to do is take some time with Zak, introduce him, and explore some opportunities that are out there on the employer side and what they're looking for pharmacy specifically. So Zak, welcome. And if you don't mind introducing yourself, that would be great.
Thanks, Mike, for having me. And thanks, Randy. I'm Zak Kornblum. I'm a pharmacist by training. I started my career at Walgreens working in a lot of rural North Carolina pharmacies, both big and small, busy and slow. About 4.5 years ago, I moved to Marsh, doing a lot of clinical work, right, helping our actuaries underwrite PBM contracts as it pertains to clinical programs and formularies and things like that. I also do a lot of strategy on behalf of our clients, so going out to the market, figuring out what the carriers and PBMs are offering, figuring out what the point solutions are offering, bringing those back in, trying to figure out, what makes sense for which client. Again, how do we underwrite it? And then I also get to do a little bit of strategy for our pharmacy group. So I sit within a group called RX Solutions, which is the pharmacy consultant within the Marsh brokerage business.
Excellent. Zak, in that vein, what are some of the main things that are being that you're providing to your team, specifically to the brokers within Marsh?
Yeah, so our core business is to go to the market, say do an RFP or a market check on those employers' PBM, bring the results back in, underwrite those, and then help them really make a decision with that employer as it relates to, well, what programs do I want, and sort of what is the expectation, both financially and in terms of sort of patient access, if I were to choose, this PBM versus that, or maybe this formulary within a PBM versus a different formulary.
And how much information do you use from the manufacturers when you do that, or are you getting at specifically through your own assets?
Yeah, so we actually don't get information from manufacturers. We will license data like Medispan or IPD Analytics, something along those lines, and then we will use that in our underwriting. But we are not specifically working with pharmaceutical companies as it relates to underwriting PBM contracts. We're starting to meet them more and more, sort of in a general sense, but yeah, it's not really flowing directly into, say, I'm bidding on, or we're working with, client X, and we want to talk to the manufacturers about their products as it relates to that client. That's not happening at our level yet.
So you're primarily relying on the PBM offering that they're bringing to your employer customer, reviewing that, putting not just an economic view of that, but a clinical view of that, and then providing some guidance and steps for them.
Yes, we are using the information provided by the PBM, and I think, data is a huge challenge in this space, right? A lot of PBMs consider the data theirs and proprietary, right? Some don't. So the amount of information you really get can vary, right? You may have to analyze a case without knowing the actual cost to the plan for products, just knowing what the mix is. And then in some cases, you may get, the mix plus the cost, plus you can have some robust rebate reporting, right? Maybe not super granular, but at least to the level where you can really understand what the rebates have been over, say, the past 12 to 18 months. So the amount of data shared really does vary quite significantly.
So would you say that practice that you're doing now has been standard over the last 5 to 10 years, or is that fair? Is it advancing in the most recent years?
So I think it really depends on the sophistication of the consultant and maybe a little bit of the consultant business model as well. A lot of the legacy consultants run what are called coalitions. That's probably an entire episode that you could do, diving into what a coalition is. They tend to focus on carve-outs with the major 3 PBMs. They tend to focus on rebates as sort of the driver of, quote unquote, savings for an employer. We don't run a coalition at Marsh. We try to be just an advisor that's sort of looking broadly across the market. And then, we've been doing this for quite a while. We've got, I think, 7 or 8 actuaries now completely dedicated to pharmacy within an actuarial department that's probably 50 plus individuals. We've hired a ton of folks from the PBM industry, right, in an attempt to really understand sort of how the sausage is made. That allows us to go deeper than just, hey, they're offering a $3,000 rebate in this channel, right? Because while that's nice, it really depends on the sort of fine print in the language, right? A lot of the legacy PBM business model is putting a number out and then using the language in the contract to slim down the number of products that actually qualify. They're obviously still earning that rebate or pulling that rebate from pharma, but the game is to create some spread in what you actually have to pass back, right? So the sophistication of the consultant, who they've hired, plays into their ability to actually dig into those details and really figure out, what does this contract really mean?
Yep. How deep do you get into utilization management practices, right? Do you quantify the use of in that analytics or the analysis, or is it something, again, relying on what the PBM believes is the best way to manage products?
So we do quantify, but I will say that it's very challenging to really hammer out like a number and to make it sort of to have a nice logic behind it, right? It gets very, very murky when you start talking about what's your PA approval rate. Well, if your PA approval rate is 75% on this product, what are the other products that person might take? It gets very challenging to have a really robust sort of number for that. And so really what we do is we assign what we think are relatively conservative but sort of fixed values to tiers of PBMs, right? So if we think you're more or less just rubber stamping, you're not going to get a strong number. If we think you're actually doing a true clinical PA, you'll get a better number.
And when you say that, is it sort of like a PA is really just a delay of the inevitable, or is it is it truly a tactic that allows you to save money?
Well, I think the idea is finding the right patient at the right dose, right? That's sort of the old pharmacy adage. There are some providers that like to sort of experiment a little bit. There are providers who maybe have a product that they're just very comfortable with. If that happens to not be on the formulary and is not rebate eligible per that contract, you want the PA process to push to the formulary, right? If you're buying a formulary because of a rebate expectation, you don't want a bunch of non-formulary products in there necessarily. So it is, I think, delaying the inevitable in that your goal is not to just deny care, but given the arrangement you've chosen, you do want the PBM's process to more or less curate the formulary that you actually bought.
Mm-hmm. Makes sense. Randy, any other questions on that?
Yeah, so as we all know, there's a lot of change beginning to happen, particularly at the state level around some of these issues that you brought up, Zach. So my question is, in the work that you're doing, how are you adjusting or allowing for some of the changes due to state law or regulations? For example, in Arkansas is a good one, where you're very limited as to what you can or can't do around and it's beginning to cause change in the benefit coverage strategies for employers.
So we've got a compliance and legal department that works on sort of the qualitative portion of that. In terms of the quantitative, again, we do rely a lot on the PBMs, right? So for instance, if they're unable to steer specialty products to a specialty pharmacy, maybe that changes what they're willing to offer financially. And so we will take that into account. One of the things with a lot of that legislation, right, is if you're in a RISA plan, ERISA is a federal law and preempts. So a lot of that just does not apply. And I know a lot of states are working, I think, in their second wave of legislation to figure out, is there a way to make that different, right? But a lot of the legislation does not apply to an ERISA plan, which most of our clients are.
Mm-hmm. Okay. Yeah, and I think that's an important distinction between the self-funded ERISA plans and the fully funded traditional commercial insurance that most of us think about. The other question has to do with what the opportunities are, because you mentioned some of these coalitions, I presume, around purchasing, not just for rebates, but what's the collaborations that are out there that you would like to see happen with manufacturers in this employer space for pharmacy?
So and Mike knows this from some of our prior meetings, right? We are starting to talk to manufacturers about what that might look like. I think what's interesting, right, is employers, they don't really even know what question to be asking along those lines, right? Nobody's really thinking, well, what if I went to all these manufacturers and negotiated directly, right? They're defaulting to, well, let's figure out how to optimize the PBM relationship. And of course, it depends on, what PBM you're with, right? The large PBMs likely would not allow small clients to get outside of their predefined contracts. The larger clients, I think they probably would, but still, you look at some of these employers, on the small side, you might have one HR person to like 200 or 300 employees, maybe 3 or 4 to 500 or 600 employees. They're not going to have the bandwidth to manage reaching out to pharma companies, or really even thinking through, okay, how do I figure out what I want to ask for if I were to go directly to a manufacturer, where some of the larger employers might have some of that, right? They may have a medical director, but they probably don't have somebody who worked in market access in their past. So I would love to see more of that collaboration.
So in what you, sorry to interrupt you, but in what you just described, Zach, wouldn't that possibly be like a TPA who's managing, maybe they have 50 to 100 employers, that adds up to, a few thousand, 10,000 lives or so, that they could be more of the advocate between the manufacturer and the employer?
Yes, I think that's absolutely it. And I think that's sort of where I was going, right? Is like you think about our pharmacy consulting group, we've got 1.5 million lives that sort of are under the umbrella, right? There's no official coalition, but they're under our umbrella, right? We can make those connections sort of quickly and easily. Coalitions can probably do the same. Again, to the coalition business model, there's a whole deep dive on that as to why it maybe would be easier to do it with someone like us versus them. But that's exactly sort of the idea that we've had, Mike, right? Is, we've got this big collection of employers and growing quickly. we can sort of be that conduit, right? We can be the one to come up with, say, the global agreement that can then be sort of distributed amongst the employers who are truly interested.
And given that, is there anything specific or one or two key things that you're being asked to provide back to the employer customers that you currently work with?
So I think a lot of the employers are starting to talk more about transparency. So obviously we're a sister company to Mercer. Mercer does a big survey of employers. I think the results there was a majority would like more transparency, but are unwilling to pay for it. Anyway, so that sort of brings us back to like the data pieces. The employers are starting to want to know sort of what they're getting for the money that they're spending. And so I think one of the interesting things about working directly with the manufacturer is you can have at least more insight into what you're spending on certain drugs versus just the aggregate, right? It helps you really uncover the real value, right, in pharmaceutical products, right? We all know that they're the tools to keep people out of the hospital, right? Keep people healthy. But it's very hard to actually calculate the real value of a pharmaceutical product as an employer because you just get this aggregate number. You know what you spent in claims and you have this, one rebate number. You can't untangle that, right? So I think working with pharma is a huge opportunity for the pharmaceutical companies to really prove out the value of their products. Nevertheless, the buyers of those products actually understanding what they're getting.
So let me ask a different kind of question because we've been talking a lot about the money side. Let's get over to the clinical side. What kinds of data around outcomes are you able to grab, and where do you think improvements around the clinical focus and clinical performance of plans comes into play in these potential collaborations with manufacturers?
So we have a group within Marsh McLennan that it's sort of our clinical consultative group, right? So there's nurses, there's a medical director, and we are collecting, claims from the TPA or the carrier, collecting some of those pharmacy benefit claims, and really pulling in other things too, like workers' compensation, with the goal of sort of watching people over time, looking at big disease categories like MS and oncology, diabetes, and trying to figure out how's this plan going in terms of the health of the patient. Mm-hmm. It's still challenging to really nail down, okay, each of these individuals, they started taking this drug and now we see a change. So was it that drug? Was it something else? The statistics are not always straightforward. Mm-hmm. But again, I think being able to sort of calculate that value requires sort of both of those pieces we talked about, right? So we can work on, watching that patient over time. We can also work on getting closer to the real price of the product, but without both of them, you can't actually calculate the value. That maybe leads into like value-based contracts, which again is something we've talked with pharmaceutical companies about. That is, to me, super interesting. That sort of makes sense, right? Clinically, you're buying an outcome, right? When you buy a drug, so why not have some sort of contract tied to that outcome? I think that the details are super important, right? It's, what data are we collecting to measure that outcome? What's the actual formula we're using to measure it? And then, from there, it's really about executing. So yeah, that's a very interesting space that we are talking to folks about and would love to keep doing so.
And to add to that, I'm not sure how much you're aware, but in my 27 plus years working with manufacturers, there's a ton of that information that's out there, and the manufacturers who invest in that are very very specifically investing, and they're really investing to provide it to the PBMs and the plans. I don't know if they've, again, I think there's sounds like a gap, like a huge opportunity to take existing data and very valid, published, in top journals types of data, and really bring that to the direct, employer who's paying for these claims, because there's real data, there's real information in that, and I know the companies invest pretty heavily in that. So maybe there's just a gap that you're not getting what you need to. Maybe you're not getting what you need from the PBM necessarily, but there's certainly information out there.
Yeah, Mike, I think you're definitely right. I think that the PBMs have done a good job of capturing the employer's attention, and probably the consultants as well. And it's just something that's just never happened, right? Like there certainly is a gap. It's not like it's hard to bridge the gap, right? It's conversations, it's sharing some information. It's just that those parties have just not come together, again, because they focused so heavily on optimizing the arrangement with the PBM, that just, whether they haven't thought about it or just haven't had time, right? It just hasn't happened.
Yeah, that's certainly been my experience over the years, similar to Michael's. There's a lot of data, but not a lot of sharing or good conversations that can help change what really needs to be happening from the employer perspective, as well as improving the patient experience, which is something that everybody's looking at these days. Some call it whole person care, others call it other things, but I think that's increasing as an area of interest by employers, as they're getting more frustrated because of the lack of transparency, even though they don't want to pay for it, as you pointed out. Nonetheless, they're trying to get their arms around this because it's becoming unaffordable in some cases, particularly when you look at the newer generation novel therapeutics that are under the pharmacy benefit, but there's a lot more under the medical benefit too.
Yes, that's very right. And Randy, I think that employers really just appreciate understanding what's happening, right? And so we were talking about, having some of that, real world data. A lot of the questions that I get is, hey, just tell me about this drug. What is going on? Why is this person on this drug? Is it the best for the condition they have, right? So I don't think employers are out there like, we need to squeeze, every last penny out. We want to say no. Like, they really, I think at this point, want to understand what their members are taking and why, right? And so that's part of that gap. It's not necessarily that you have to have this super complex formula for calculating value. You just have to be able to tell the employer, this is why this person is on this product. They're on it because it has proven medical benefit. Again, that's something when you've got a couple of HR folks and the CF, like, they're not pharmacists, they're not physicians, they're not inherently going to understand this. You have to communicate it. And so I think a lot of this transparency talk would be resolved simply by better communication of why people are on certain high cost products.
That's really well said and very clear. And I think that's what gets missed, right? In all the noise of transparency and compliance laws. It's really about just being open and not assuming a consumer ad is what drove the patient to get the medicine they have, and we all know that that's not always the case. But this has been great. Randy, did you have any other follow-up questions before we let Zak go?
No, I think this has been a great conversation and timely in terms of your experience, Zak, and what you're seeing in the employer space, and some of the outreach that is underway with manufacturers is also very interesting. So thanks for sharing.
Yeah, absolutely. I appreciate you guys having me on today.
Yeah, and hopefully I have it back on again, and we can maybe get you on that coalition conversation.
Yeah, absolutely. We could definitely have that one. We'll be looking forward to that.
Awesome. Well, thanks, Zak, for your time and your efforts and all the work you're doing. It sounds like you and Marsh are doing some amazing work for your customers. And we look forward to having another discussion about it.
Absolutely.